Okay, now we're going to talk a little bit about hemophilia. Hemophilia, of course, is a sex-linked recessive um, disease. There are three main types of hemophilia. Factor A, type B is factor 9, and von Willebrand's is another one. So those are the three main ones that have to do with hemophilia. Um, there are patients out there that have hemophilia. They live pretty much normal lives. They're very cautious. Um, they can do a lot of things. Some things they can't, but they're pretty cautious on what they can do. So if somebody cuts themselves, they hit themselves in a joint, that's when you end up having problems. So, for example, usually it's a slow bleed. You're hit in a joint. It may not bleed immediately in the joint. It may be hours or days delay. Um, it can be uncontrollable hemorrhage, internal, cut yourself, a nosebleed that won't stop, gastric ulcer, things like that. GI problems, trauma, obviously, broken leg, broken arm, car accidents. Neuro comes in if hopefully you don't fall down and hit your head and have a bleed in your brain. The other thing neuro-wise is depending where you're bleeding in the brain, it could cause a paresthesia, it could cause compartment syndrome, cut off circulation, oxygen to tissues, and that's the neuro piece of it. So paralysis, um, things like that. Hemiarthrosis, the joint bleeding. So they basically do blood tests to find out which factor the patient's lacking. Sometimes kids are diagnosed with this when they notice they can't stop bleeding for some reason. Somebody may be a late teen, early adult before they ever have a problem, and they aren't even diagnosed till later instead of children. So care for these patients when we do it, if we have to replace that factor, they give the factor. It's better to give it. The problem lots of times they give it too late or they stop the factor too early. Factors when they're given, they're called cryoprecipitate. It can be given IV, it can be given sub-Q. The key is to stop the bleeding, so pressure, ice on bleeds. That's the number one thing you want to do. These patients should not be taking aspirin or any other thing that's going to prolong bleeding. When a patient has bleeding through hemophilia using their joint, it's very painful. They're going to require a lot of analgesics. Morphine or opioids are going to be the best one. Using ice. They need to rest, especially if it's a joint. So joint rest. As soon as the bleeding stops, they have to start moving those joints so they don't become permanently fixed and cause contractures. You don't want to be crippled by that. So bleeding, sorry about that. Bleeding problems with hemophilia. So the key about that is giving the cryoprecipitate, stop the bleeding, use ice, use pressure, make sure the joints don't fuse and become immobile. So we want to do the best with that. DIC, it is basically a disease that is caused by a trauma. It could be caused by sepsis, caused by a whole bunch of different things, and basically your body is overloaded with forming clots and breaking up clots, and these patients basically have an acceleration of clotting and an acceleration of lysis. So these patients are at a high risk basically of they form little clots and the clots are broken down. So some of these patients have a lot of bleeding issues. Some of them can actually have problems where they're making too many clots, so a risk of bleeding and a risk of causing clots. So these patients could be either forming DVTs or clots that could move, emboli, or they could have active bleeding. DIC can be brought on by patients that have trauma, sepsis, critical care patients. Sometimes this will lead to horrible failure, multi-organ failure. So this is not the thing that you want to see patients going into. There's different ways to treat this by giving them platelets. If they need platelets, if that's reduced, they can do that. If it's a problem with breaking down the lysis of clots, then maybe giving some heparin will help them. Everybody's treated a little bit differently. Not one thing is going to work for everybody, so they really have to figure out what's going on with the patient. So patients that have the bleeding component with DIC, bleeding's going to vary. They may be forming petechiae, purpura. They may ooze blood from venipuncture sites, things of that nature. So it could be a wild manifestation. If somebody goes into DIC for years, it's not quite as bad, but it used to be if a patient goes into DIC, usually in critical care, it is not a good sign. That was always known as, oh my gosh, they're in DIC. Well, death is going to be imminent. Not everybody does it. It's not a real common thing, but it sure has a high morbidity rate with that. Here's an example of a petechiae, just a little bleed, usually caused by thrombocytopenia. Here is an example of purpura, or a lot of petechiae. Here is a lot internally. I hope this patient wasn't alive when we took this picture, so maybe this is post-mortem with all the petechiae and purpura. Here's a lot more. It's probably bordering on purpura. A lot of petechiae here are close together, so purpura. So testing. What kind of testing are we going to do with all the different bleeding and patients that are receiving heparin, receiving Coumadin, things of that nature? Well, these are all the different kinds of tests that we have for blood work. So the prothrombin time, also called INR, that's just basically your bleeding time. How fast are you forming clots? That's the #1 test that you do for patients that are taking Coumadin. The partial thromboplastin time is used for heparin. So for patients on heparin, we do a PTT. Also APTT is also for heparin. That's another one. Thrombin time basically is testing for fibrinogen. So it's testing how much fibrinogen the level is. That's a piece of it as well. Fibrinogen, you can just test that closely and find out the function, the level function of your fibrinogen. You can do platelets level, which we've already talked about. So thrombocytes, what's your platelet level? Less than 150,000, of course, is thrombocytopenia. The patient may not have symptoms at that point. D-dimer. A D-dimer test is basically figuring out if there've been clots that have formed, and this is the disintegration of clots. So this goes elevated when clots basically are lysed, broken down. Another one is activated clotting time. That is also used with heparin. So if your PTT is too high, you can do an ACT and get it. It's more of a rapid test. So your protein C, basically, if you have a decreased protein C, you are at a high risk of DVTs. So neutropenia. Neutropenia basically is, we think of it as leukopenia. So your total decrease of your WBCs is leukopenia. Neutropenia could also be the decrease of your neutrophils. Those sometimes are used interchangeable. Someone will have leukopenia and it's really the neutrophils. things like that. So you might hear both of them. So neutropenia really is when your neutrophils are less than 1,000 to 1,500. This can be life-threatening, obviously. Um, Risk factors for patients that have that as well. Risk factors, obviously, are you're going to get an infection that um, you can't get rid of. You can't fight it off. So the patient becomes very septic. People can die from having no WBCs because of the takeover of fungal or bacterial infections. If you're diabetic and you're also neutropenic, well, you're not going to be able to heal very well. Um, so think of the WBCs. What is it when we form purulent matter in a wound? Purulent matter is caused by WBCs. If somebody has decreased or neutropenic and no WBCs, they cannot fight that off, and so they consequently cannot make purulent matter. Um, so you get a fungal infection, viral infection, bacterial infection. So all of these patients basically are at a risk of becoming overpowered by an infection. So the key for these patients is, if they're neutropenic, want to find out why. If we can fix that, we can find out the organism, get them the antibiotics. That's the important thing. If they are, it's just a matter of the bone marrow making um, extra WBCs, we can give them sub-Q Neupogen. For RBCs, we give Epogen. For WCs, we give Neupogen. We also have to protect their environment. Hand washing is probably the #1 way to protect their environment. Everybody washes their hands. That's important. If someone is sick, they shouldn't be around sick patients or sick people as well. So anything that's going to decrease getting an infection. So what can bring on neutropenia? Well, it could be chemotherapy, radiation therapy, severe sepsis, if they're not eating properly, so it could be nutritional deficiency, could be having diagnosed with leukemia, things like that. So cultures are important. These people, if they have a temperature greater than 100.4, that is a neutropenic fever, and that has to be jumped on very quickly. Antibiotics should be given within an hour of anybody having a fever of 100.4. Get the cultures, get the antibiotics started. Signs of septic shock, we need to watch for that. Give them the Neupogen if that will stimulate it. So if we're giving patients antibiotics that fall in the category of aminoglycosides, which are also the mycin family, those are nephro and ototoxic, so that's important to know. So these patients, we need to get them through that. And how do we do that? Well, we have them stay away from others. Anybody that's sick, they shouldn't be eating any fresh fruits and vegetables. Sometimes they need to be isolated from others. Everybody washes hands. Everybody wears a mask. They should be in a private room, maybe on a high flow room, so we're not putting any bacteria through the doors when they're open. So a private room with high flow system. Patients need to be careful about drinking tap water. Maybe it should only be bottled water. Anything that's going to cause an infection, we need to do away with them.